Hello, my name is Camilla Main. I'm consultant midwife for East Midlands Ambulance Service and lead midwife at London Ambulance Service.
Hello, my name is Susie Rind, maternity quality and governance practitioner and paramedic at North West Ambulance Service.
And hello, my name is Dawn Kerslake, consultant midwife at South East Coast Ambulance Service.
With various other midwives and paramedics working in ambulance services across the UK, we have led the guideline update groups which have undertaken a full review and update of various JR-Calc maternity guidelines, including imminent birth, cord prolapse, and we've also created a new pre-hospital maternity decision tool. These guidelines will sit in the maternity care section of JR-Calc clinical guidance on the JR-Calc Plus app.
The imminent birth guideline has been fully revised and updated and includes wording to identify when birth is imminent and when to consider conveying to hospital. The guideline now includes sections on free birth, water birth, home birth, and on-call birth. The APGAR score has been removed and has been replaced with a revised management algorithm to support ambulance clinicians when on scene. There is a new table outlining high-risk pregnancy features and photographs that give a visual guide when estimating volumes of blood loss.
Cord prolapse is now a standalone guideline, which is found in the maternity care section, and it has its own tile on the JR-Calc app, as well as its own management algorithm found independently in the algorithm tab. We would recommend that you use the algorithm as one place where you can find everything that you need in the heat of an emergency.
Pre-hospital maternity decision tool is an entirely new tool developed to identify abnormal parameters, abnormal signs, and abnormal symptoms in pregnant or recently pregnant patients. The tool will sit inside the maternity overview guideline, and it will be available in the algorithms tab for ease of access. The tool should be used whenever attending patients who are pregnant or suspected to be pregnant, regardless of gestation, or up to 4 weeks after birth, or after a pregnancy loss, or after a termination of pregnancy. Remembering that these situations might not be immediately obvious. It should be used in conjunction with clinical judgment, relevant JR-Calc guidelines, and local guidelines.
These updates have been made following reviews of incidents across the UK and using latest evidence on reducing morbidity and mortality for pregnant patients. We have separated the guidance on the app to make it easier to find. The imminent birth algorithm, cord prolapse algorithm, and pre-hospital maternity decision tool are reference guides to support the clinicians when making decisions on scene. The cord prolapse guideline emphasises the need to minimise on-scene time and transport under time-critical conditions. The algorithm shows the position that the patient should be recommended to adopt whilst transport is being arranged or arriving, and it further recommends how to help the patient to apply a pad and walk to the ambulance where possible as soon as transport is available. Just to reiterate then, we really want to reduce on-scene time and emphasise the importance of this, and furthermore that this is a time-critical maternity emergency.
The imminent birth guideline includes a recommendation for a continuous dynamic assessment when on scene with a patient in labour. The recommendation is that if birth is assessed as being imminent, the clinicians continue to assess for progress every 10 minutes. And if birth is not progressing, then the plan to stay on scene is changed. This is because there are a number of physiological situations where, despite regular contractions and an urge to push, or the presenting part is visible, the birth may not be truly imminent. Following the birth, the guideline recommends moving to hospital if the placenta has still not birthed within 20 minutes of the birth of the baby.
The pre-hospital maternity decision tool has been developed because News 2 shouldn't be used in women who are pregnant or recently pregnant, because the physiological response to acute illness can be modified by pregnancy or recent pregnancy. These patients can compensate differently to non-pregnant patients, and this increases the chance of us missing signs or symptoms of an unwell patient or an unborn baby. The pre-hospital maternity decision tool is based off the evidence-based maternity parameters on the new National Muse Maternity Early Warning Score. However, the tool uses red flags because the escalation thresholds have to be lower in the pre-hospital setting, because in the pre-hospital setting, we're limited on resources, diagnostics, training, the environment, and we don't have access to fetal monitoring. Therefore, the scoring system used in a hospital setting would not be a common language to the pre-hospital setting. And we're also not trying to identify trends in the woman's care, but we're trying to identify patients that are requiring time-critical assessment in a maternity unit. It's worth thinking about the fact that pregnant patients can be a proxy for fetal well-being, and we don't have access to fetal well-being monitoring in the pre-hospital setting. So, for example, the first signs of chorioamnionitis, which is an infection of the amniotic fluid or membranes, can be a slight pyrexia, which is why a slight temperature is a red flag in the pre-hospital setting, despite there being differential diagnosis. A red flag will require an assessment in hospital, even if there are not other red flags that are identified. So, for example, bleeding in pregnancy is always a red flag requiring a time-critical assessment, even if the woman's observations are normal. There's also an emphasis in the guideline on not calling for advice when red flags are identified. This is because the ambulance service has responsibility for the patient at that time, and the advice line into a maternity unit is not routinely subject to governance. And there's been a number of incidents where red flags have been identified, but then following advice from a maternity service, the care has been inappropriately de-escalated. Therefore, we would recommend that you use the tool, and if you require further advice, follow escalation pathways within your ambulance service.
We would really like to take this opportunity to thank the wide range of stakeholders and reviewers that have been involved in the development of all these guidelines and indeed the new tool.